Welcome and thank you for joining us. In this clinical spotlight, we'll be exploring the Aristotle test, Therium's flagship health assessment that applies systems biology and advanced metabolomics to deliver personalized, data-driven insights into an individual's metabolic health. This interview is part of our ongoing effort to equip clinicians with a deeper understanding of how the Aristotle test can be integrated into everyday practice, whether for chronic disease prevention, optimization of patient recovery, or precision wellness strategies. Today, we'll be joined by Gus Vickery, MD, a leading expert to discuss the clinical value of the Aristotle test, its unique biomarker architecture, and how its multidimensional data can guide real-world therapeutic decisions. Dr. David Augustus Vickery, or Gus Vickery, is a board-certified family physician and founder of Authentic Health in Asheville, North Carolina. For more than 2 decades, he's pioneered concierge-style data-driven care, leveraging genomics, advanced biomarkers, and lifestyle coaching to reverse chronic disease and optimize performance. He's the author of Authentic Health and a sought-after educator on precision medicine. Today, Dr. Vickery will share how our Aristotle test has become a cornerstone of his individualized protocols and the tangible impact it's having on his patients' lives. So let's dive in. Dr. Vickery, thank you for being here today.
Yeah, thank you, Panise. I'm delighted for us to once again go through patient reports and learn from each other.
Absolutely. So, Dr. Vickery, tell us a little bit about the case study you have prepared for us today, and also, generally how you use Therium in your clinic.
Okay, so we're going to walk through some data, including the therium testing on a female patient who's approaching 50 years of age, who established into our clinic because she really wanted to do a big push to get healthier. She came to see me several years ago and was and actually a friend called and said, would you please see my friend? Because she was in a pretty challenging state. She was having supraventricular tachycardia. She had been placed on steroids for a skin eruption, and now that was blowing up on her. So she was covered up in this rash. She had tachycardia, and she was also under enormous pressure and stress in her life at that time. And we thankfully we were able to kind of figure out how to calm her system down and get the rash to resolve and kind of get the tachycardia to go away. And then subsequently, her husband ended up undergoing liver transplant. So their family went through a lot, and I didn't really hear from her for some time. But she contacted the clinic and said that, the husband was great and doing well, status post-rail liver transplant. Their kids had gotten older and things had settled into a good rhythm, and she was ready to dig in on her own health and figure out what she needs. Like most people who are approaching 50 that have children and a business, she's tired, has occasional sleep disruption, has some, concerns around skin, acne, rosacea, eczema, things like that. And her gut's not perfect. But overall, she's a pretty healthy individual. She doesn't have any medical diagnoses. She's not treated with any prescriptive therapies. She assumes maybe she's approaching menopause, but isn't really sure about that at the time. So that's where the context she came in, and she wanted our most robust program for data assessment. So that with that, we go ahead and get a full toxicant assessment, a gut assessment. At this point now, a Therium Aristotle test is part of that package. We also do a test called a prodrome test that looks at some unique variables. We do a full blood set. We do a DEXA for body composition and bone density. We do carotid intimal medial thickness testing to look at endothelial function and risk of atherosclerotic plaques. And then we also do an epigenetic age test, right? So we look at that lens too. So we just take a lot of different pictures of the body from different angles, and then we stitch all that together into a cohesive story for that patient to identify what are the variables that are having a potential negative influence on her health that we can begin to modify so that she can move into a state of one, just normal health, but then optimization. This is someone who wants to go into optimization and get the most out of her mind and body. One of the interesting things that from the time I had first met her to when she came back in, she had actually lost a good bit of weight, and about 20 pounds, and looked healthier, and she wasn't really getting into fitness training yet, but she had done a lot of things to just improve her health over that subsequent period of time that I had not engaged with her. And just real quickly with the Therium Aristotle test, I started running these about 6 months ago. I got introduced, of course, to you, Panise, and Micah about a year ago. We met and we talked through the technology and what I do and what you do. And it took me some time to really get my mind around, one, well, let me back up and just say, I had been hoping we would have actionable metabolomics reports for a decade, right?
Yeah.
I knew that if we could accurately, that it wasn't, can we measure the metabolome? The answer to that was yes. And there were companies doing that, but could we real accurately interpret it across all of those domains of biochemical function, cell function, and ultimately human health, and then know what to do with it, right? What are we going to do on an interventional plan? And so this was a tool I've been looking for a long time because it's actually the tool that stitches everything else together for us now. Whereas before I had to, and I still do use my own brain, but I had to do all the stitching myself. And I had to infer things and kind of guess into the areas where we didn't really have the data and come up with protocols. And now we're able to look at, as we will in a moment, as we look at this report and compare it to the others, we're able to look at the Aristotle report and index, the biochemical impact of toxicants. Is there really a mitochondria problem in someone who's tired, or is it something else? And so it was something I was really excited to be able to introduce, but I knew that to some extent we're going to be dependent on the algorithms that the AI is producing because the complexity of the system, the complexity of the analysis really exceeds one human brain's ability to accurately interpret. So I
Yeah.
needed to build up my trust in your team and the
Yeah.
technology because I knew that I was going to be stepping out on a little bit of a leap of faith by using the report, following the intervention plan. But over the course of that vetting, I felt like the trust was well validated, well supported. So I started running these reports 6 months ago. It's initially just a trial on a subset of patients. Now they're included in every one of my packages. Like if you come to work with me, you will be getting a metabolomics test. Right? Like, I mean, there's other things we may or may not do, but you will absolutely be getting a metabolomics test. I consider it an indispensable piece of precision medicine.
Wow. Yeah. And so really you're using our Aristotle test as a routine measurement for anybody that's coming in through your clinic. And at times when you need to get an in-depth assessment of the alimentary canal and gut health, then you're using the ilia as needed for that extra snapshot. That's
That's right.
excellent. And that's
Yeah.
excellent. Yeah. And I totally understand the sentiments you're expressing, particularly around the complexity of AI and the
Mhm.
answers that it often provides, even for us who have to then sort of reverse engineer its answer and see, really go back into the decision trees, as it were, and figure out why is it stratifying or classifying this person into this subgroup and recommending this intervention. It is kind of a black box, and you have to test it out and see and really highlight its analytical prowess in case study environments like the one we'll discuss today. So I will be, helping you sort of pull up the labs
Yeah.
here, the anonymized labs that we have. Which one should we start with? I'd like you to just walk me through it as if I were the patient.
Okay, so what I'm going to do is exactly that, but I'm going to walk through the tests because this is exactly how I do it. I usually present their blood tests, then I present like the specialty tests, like a prodrome test, the toxicant. In this case, I'm not showing the CIMT, the DEXA data, and all that kind of stuff, and then I present the Aristotle because, like I said, I feel like it stitches it all together for us, and
Excellent.
yeah, and so that's what we're going to do, and I'll share my screen first because I have those blood tests. And we're going to move pretty quickly through the blood
Yeah.
test cells. This
Great.
will be
However,
quicker
quick or
with the
fast.
patient. This will be quicker with than with the patient because
Okay.
I might, for them, they've made a big investment. We've got a couple of hours and they may be really interested in getting more granular, sometimes not. So I still use Boston Heart for lipids, lipid particles, primarily because I want to look at oxidized lipids. I think that's an important marker and then this cell membrane test. So when we can look here, we can see that for a approaching 50-year-old female without diabetes, without hypertension, without strong vascular risk in her family, this is a pretty healthy cholesterol profile, right? I mean, so you can see that her total is 191, her LDL is 101, her her HDL is 78, and triglycerides 53. So for this individual, there's really not a lot to see here. Right. This is not where we're going to like focus in our time and effort. And ApoB levels are very healthy at 71. Small dense LDL is optimal. I had already assessed her for lipoprotein A the first time I evaluated her. So that's why it's not on this assessment because she didn't express it. I also ran other tests the first time I assessed her several years ago when she had come in with those complaints like cholesterol balance tests, sterols, cholesterol synthesis pathways, but I didn't reproduce it because there was not much to see there.
Great.
So, but this one's an important one to me. And I will tell you that when I am seeing oxidized lipids, Therium will typically report lipid peroxidation as a problem on the tests.
Okay.
Sometimes it'll be normal and it's still picking it up because you might not be able to measure it like through a biomarker like that. This is a cell membrane test. So it's done on the red blood cell membranes. It's about a 90-day proxy for the average fatty acid composition of membranes in general, and then also the essential fatty acids that are coming into the system. So we see that, not optimal. We have an elevation in the saturated fat index, 34%, which, as you know, Panise, can lead to stiffer membranes, less fluid, flexible membranes.
Yeah.
And trans fats look good, but her overall omega-3 fats are not optimal, right? So she's, well under index. That's
Indeed.
going to have some impact on the saturated fatty acid index, because if you're taking up less space with these, you're going to end up with more of those.
Yeah.
The other thing I'll explain to people is that saturated fats are dietary, but also our body can manufacture them, right? We can bioconvert in our liver of monounsaturated fats into saturated fats, and we'll commonly see that in individuals who drink more alcohol or have fatty liver or obesity or insulin resistance and diabetes. So not every time we see a high saturated fatty acid index does that mean that they're actually consuming too much saturated fat in their diet. It can be due to other reasons, but these are only dietary or supplement, right? These omega-3s. Your body cannot produce those. So that's what's coming into the system. And then we can look at linoleic acid, arachidonic acid, and monounsaturated fats. Overall, not a lot to see here. A lot of times, if people are having real challenges with body composition, insulin resistance, we will see very high levels of linoleic acid, and then we'll kind of target that as dietary wise to try and reduce that to more optimal levels. We do a GGT, just a separate marker for liver stress, cystatin C to look at kidney function through a different lens, and then CoQ10 levels. This is just a serum
Sure.
CoQ, yeah, but we can see it's low, right? And so obviously the first thing that I know if I didn't have therium on this patient is we've got an issue with essential fatty acids and we have some depletion in CoQ10. It doesn't always mean this, but it typically would mean there's probably some mitochondrial impairment, some cell membrane issues at the very least.
Yeah.
Possibly inflammatory issues as well. Right. So
Right.
those are things that I would have said probably happening just based on that data. But now Therium helps me really confirm it. Yeah, so this is a standard blood profile, a blood count. People have seen these before. Her hematocrit's borderline high. The rest of that, there's not much to see. Fibrinogen levels, standard metabolic panel with serum electrolytes, kidney function markers, liver markers, biliary markers, total protein. All of that looks good. I know that there's nuances. Any physicians or clinicians watching this know there are nuances to the reference ranges and patterns within patterns, but the point of today's discussion isn't to go into that level of depth about these, but really cross-match it with the Therium test. So we can look at hormones. Her overall testosterone level is normative, and her free testosterone levels are in the normal range, on the lowish side of the normal range, but in the normal range. Vitamin D is in the normal range. Could be considered not optimal. Again, this is a spot check, and it depends on where she is in her cycle. Obviously, the pituitary hormones are trending in a direction that could suggest perimenopause, but we'd have to do these in sequence over time to really prove that. But when your FSH is getting up to 30, typically, and you're almost 50 years old, probably there is some beginning of ovulatory deterioration in terms of function. And then we can look at, and then the estradiol level of 14, but of course she was just coming off a period. So what we would expect to see is a lower level of estradiol and a lower level of progesterone. So it was
Sure.
normative for that time. If we wanted to know ovulatory function, of course, we would look at a estrogen level around the time of ovulation to see, are we seeing that big surge in estrogen? Screen, usually I have thyroperoxidase antibodies and thyroglobulin antibodies. For some reason, the TPOs weren't done, but we don't see that signal. Iron studies look good. Uric acid is 3.7, which is technically normal, but that's a little bit low. which can actually imply a lot of times when you see lower uric acid, there's impairment in cell functions, and that can be sometimes just protein insufficiency in individuals. They're not getting enough protein, but there can be other things. B12 is really high because she's taking a bunch of B12. Ferritin's 184, which is not optimal, and she's a menstruating female, so we know this isn't iron overload, and she doesn't have hemochromatosis. So for me, if the ferritin's exceeds 100, then we have reasons to want to proactively try to lower that based on a lot of data correlating ferritin to many different disease states. When I see a level of 180, that can be liver stress, it can be insulin resistance. She doesn't really have a pattern of that. I usually put it in the compartment of oxidative stress, that there is an oxidative stress issue with that patient. You can see blood glucose regulation looks great. Cortisol levels this is a serum cortisol. It's not the best way to assess adrenal function, but it is a helpful screening test. So she's right at a 10, kind of normative, maybe a little bit low for a mid-morning cortisol. Thyroid functions look pretty good. Free T3 isn't in the optimal range. These are discussions we have with the patients. Again, my point isn't to like do the full consult, but index to theriome. Is that all right, Panise? Rather than
That's exactly
yeah,
what we were
yeah,
looking for.
good.
Yeah.
Yeah, so I'm not going to get into the granularity of the thyroid discussion and stuff like that.
Sure. Yeah.
Yeah, yeah, C-reactive protein less than 1. Fasting insulin is low, right? And a lot of people think,
Glucose was low too.
yes, exactly. She was hypoglycemic at that time. She didn't realize it. She didn't really feel it, which made me think she may, because she's gone through this weight loss, that she may be well fat adapted and ketone adapted, and that even though her blood sugar is 50, she's producing ketones and her brain's using them. I'm theorizing here, but she's producing ketones because I asked her very carefully, were you dizzy? Were you shaky? Did you feel weak? Nothing. No symptoms at all of hypoglycemia with a glucose of 50,
And
right?
what was your diet like?
It's a pretty healthy diet at this point because that was a lot of what we worked on in the beginning. She eats a Mediterranean style diet, tries to make sure she gets sufficient protein, but actually at the time of this evaluation acknowledged she probably had not been hitting the kind of protein target we would assess for her. But she was oriented towards cleaner, less toxic, but as you'll see from her toxicant report, not completely. Yeah.
That's
Yeah.
that's a surprising amount of time.
Yeah, but in this case where we see a glucose of 50 and an insulin of 1.1, then we're like, okay, we're not really gonna we would need to really recheck a fasting insulin and a normal glycemic time to really know beta cell function. But if I see a low insulin in a younger healthy person with, they say, a normative glucose, that can be problematic. There are cases where people are reducing their beta cell function. They could extended ketogenic diets can do this, and you can actually end up developing a pattern of insulin resistance later, just based on downregulation of functions of the body. But I'll commonly see it, and it's not. I don't know if there's any literature on this, but this pattern of low uric acid, low insulin, and a couple of other markers that I can look at will often index to just a low protein diet. People are just not eating enough protein. And I can't tell you exactly why, but we'll have them get a protein target and hit that protein target, and we'll typically see insulin normalize and uric acid normalize. Yeah, I'll let your biochemical brain work on the puzzle.
Low uric acid, correct?
Low uric acid, yeah.
Well, that kind of does make sense. Uric acid would be a byproduct of nitrogen metabolism. And so
Exactly.
if we're putting in the protein, we're going to get that to go up. And then with a certain range of protein, you may have insufficient low insulin.
Hmm.
But if you are putting in sufficient protein, insulin is still going to be functioning. So
Hmm.
I could see why insulin and uric acid would alleviate with added protein.
Yeah, exactly. So
Yeah,
DHA looks
very
good.
interesting. Yeah.
Yeah. Homocysteine, IGF-1 levels are on the very low end of the range. She's been losing weight, but hasn't really been doing muscle training. She's not getting enough protein. So obviously this is an area for body comp and fitness and bone health that we can target using, say, peptides, et cetera. Zinc levels are, in the kind of they're in the normal range. Copper levels are in the normal range. Balance isn't quite perfect. Interleukin-6, inflammatory cytokines undetectable, which is good. So, the big picture is that, this is not somebody who's got this like very concerning pattern on their labs, right? They've got evidence of essential fatty acid deficiency, maybe protein insufficiency, low CoQ10 levels, some elevations in ferritin, lower uric acid. So there's clearly some impairments in biochemical performance in this body, and we would expect that to produce some fatigue and not feeling your optimal self. And historically, we would have designed protocols to address those findings, and including the oxidative stress, we would have thought about nitric oxide, glutathione. We would have looked at other molecules that can boost mitochondrial performance, NAD, and preloaders to NAD. Again, we're going to work towards the theriome and talk about how that really made it a lot easier to know exactly how I would want to intervene and eliminated a lot of the guesswork. And for the audience, I don't have a financial relationship with theriome
No,
whatsoever.
no,
Right? Just to be
no.
clear, right? Like with the things that I'm saying about what this report has done to like make my work more precise, easier, and more effective, or just sincere, I'm really, really grateful that we have this technology available. It really is a game changer in
And
how we.
and and I will add to that and say that Therion doesn't have a financial relationship with any of the physicians on our
Yeah.
practitioner platform. We do not give any free testing or discounted rates.
Nope.
It
They
is just
don't they don't give me free testing.
we do not. There is nothing like that. It is really just an idea as to how can we bring the scientific expertise with the clinical excellence of physicians like Dr. Vickery. And so I'll let him continue, but I think, yeah, that was a good caveat to make.
Yeah, but I mean, it really is. I'm very, I mean, I firmly believe that in this space of multiomics, and when we get to proteomics and transcriptomics, and you and I have talked about this is the future of medicine. This is the future of human health. And we need these tools because of what's happening to our population. The deterioration in health of our population is due to a lot of variables that are not being measured through routine checkups at this point in time. And so the ability to detect those things earlier in healthy people, where they probably just have little subtle shifts that they need to make to optimize, or in people who have complicated medical challenges. So that's enough said, obviously, but I have a lot of confidence. And I've been able to prove that confidence through hundreds of patient evaluations over the last 6 months, where I do have this additional data compared to. This is a specialty test called a prodrome test. Diane Goodenow out of California created it. It's primarily to pick up signal for neurodegenerative diseases, but there's some good information. I'm going to be very quick about it. We're looking at sufficiencies as an inventory. Does the body have what it needs? So we have phospholipids, which are critical and commonly depleted, but not in her case. Her phosphatidylethanolamine levels are very healthy, and her phosphatidylcholine levels are very healthy. So she actually has really good levels of phospholipids. At baseline, most people that I assess who do not eat eggs are way down here, very,
Mhm.
very depleted in these phospholipids. And then the other important variable are the plasmalogens. Not everybody is aware of what a plasmalogen is. It's a derivative of fatty acid. It plays a protective role for cell membranes. They get consumed by inflammation, oxidation, but they're protecting our membrane complexes. And plasmalogen depletion is a risk factor for neurodegeneration and cancer. So that's what I really want to know. And when we see that the plasmalogens are lower, what we expect to see in a healthy state is that the plasmalogen will be equivalent to or higher than the corresponding phospholipid. So we're expecting in the healthy individual to see this up here and to see this up here. Now, she isn't what we call plasmalogen depleted. It's not like they're just bottomed out and she's at risk of neurodegeneration, but she is having elevated consumption. And that what that indexes to is oxidative stress, especially around membrane complexes. Right. So we know that we've probably got a little challenge in this particular area. And then there's an inventory on fatty acids, on the phospholipids, and then dietary fatty acids. And we can see that her DHA levels indeed are suboptimal, right? But she has very good omega-9, oleic acid. And I won't go into the gastrointestinal tract acids, but they're normative. And then we can look at cell functions. And again, you have to spend a lot of time learning his methodology for interpretation, and that's not what we're here to do today. So I'm just going to be very quick. But for methylation, this is just one lens on methylation, right? There's a lot of ways to look at it, but he's looking at it from the lens of phospholipid availability, sphingomyelin and ceramide ratios, and homocysteine levels. We know that there is some methylation impairment, primarily because her sphingomyelins are depleted compared to ceramides, right? And so we can say that's going on. And then when we look at, this is specifically looking at fatty acid oxidation for mitochondria, whether you're utilizing the acetyl-CoA units that are cleaved off the fatty acids for producing energy, or whether they're ending up just being tacked back onto fatty acids in elongation. The pattern overall is decent, but there's a mild amount of fatty acid oxidation impairment based on this assessment. Inflammatory review is pretty good. And then peroxisomal function isn't optimal, primarily because of the plasmalogen depletion that's going on there. So I know that was quick, but in a moment, we're gonna take this and carry it over to our therium. I mean, and so historically, before I had therium, I had the data that we've been looking at, and I also had, of course, a gut test, and I also had the DEXA and the IMT and all the subjective health history of that patient, family history, plus a genetic report. So I had a lot to work with. And so there's already a pretty robust story we can tell about this individual, and then doing some guesswork into, well, what are the mechanisms? This is her tox report. Okay. So this is just an inventory on what's in the system at what levels. And we can see here, we've got mold toxicants at high levels. We've got lead. We've got parabens, bisphenol A. This is not good, And then at moderate levels, we've got other mold toxicants, other heavy metals, glyphosate. It's not bad, but it's there. So Roundup wrecks the gut biome, obviously. Now, what you're going to see is that there's some prior levels, because back when she was so sick, I ran a tox report on her. And you can see it was very bad back then. And we ran a protocol that she did, but then I didn't hear from her for 2.5 years. But actually, you can see her levels are a whole lot better than they were 2.5 years ago when we.
Yeah, yeah, we see the historic data shaded out there.
Yeah, so I mean, there definitely was improvement, but there's still a problem. So we definitely have a
We have
toxicant.
mold, we have plastics, and some heavy metals.
Yes, and then like glyphosate for me is gonna. I
And
know what I'm gonna
pesticides.
start seeing. What I'm
Yeah.
gonna start seeing on a gut report when I see high levels of glyphosate. We know. All right, so we got a patient. She's not sick. She doesn't have chronic diseases, but doesn't feel as good as she like. She wants to be healthy. We see markers of oxidative stress, high toxicant burden, cell membrane issue. I mean, so there's a lot that we would be able to put together, and we could put together a pretty good protocol for her based on that. But I'm going to let Penise pull up her Aristotle test,
Yeah, absolutely.
and I'll
So
stop my
here
share.
is her Aristotle test.
Let's look at these domains that were assessed through Therium and compare them to what we've already seen in her data and see, is it congruent? The answer, of course, is it is congruent. So,
Yeah. Yeah, so I do see some, right off the top, I can see some diminished mitochondrial activity. That could be due to a number of things. It could be cell membrane health. It could be, fatty acid beta oxidation, as you mentioned, looking at her prodrome results. I do see maybe potentially some issues with ATP or niacinamide. We'll see. Her inflammatory index is really great. I don't see a whole lot of inflammation. It's right on the cusp of being optimized. I saw her
nor did you
inflammatory.
measure that in her serum markers either.
I did see some CRP that was at low levels, and so
The one on the prodrome test, I don't, I actually, honestly, I like the other one. It was 0.8. He measured it at 1.03. So, and then interleukin 6 was normal. Anyway, I didn't see like what I would call an inflammatory pattern.
inflammatory spike. Yeah, yeah. What I'm seeing is some measure of mutational load that could be due to mutagenesis, increased oxidative stress that creates genomic instability, or an impairment of those DNA repair enzymes that are meant to find and correct mutations. And then, of course, I do see, heavy environmental toxicant burden. And that's popping up really in the poor range.
Yeah.
Everything else is essentially um, dead normative, uh,
Hmm.
kind of where we would expect someone of her demographic to be. The throughput of the metabolite fluxes are really normative. You see some improvement here in aging index, so metabolites related to longevity are doing fine. But really,
And she's actually using stacks of bioregulatory peptides, which do have a pronounced influence on epigenetic age
on
markers.
epigenetic, there we go. There we
Yeah.
go. So
Yeah.
really, I would say, one, two, and three concerns would be the environmental toxins, the mutational load, and some issues with mitochondrial health.
Yeah, which ties really in nicely with the picture we saw. Her toxicant report clearly a lot of concern finding there. We see big biochemical impact from those toxicants. It's affecting her system.
Sure.
Clearly, that has a spillover effect into the mutational load, DNA damage, DNA repair. It's not the only thing that it does, but also on the nutritional index, right? I mean, I know it falls into the
Really
normative
low.
range, but it's not optimal, right? And so we know that, I mean, I had already kind of inferred protein insufficiency. We know there's essential fatty acid insufficiency, and she wasn't using any type of full spectrum micronutrient support. So I also knew she likely has a substantial, I mean, at least, a significant amount of nutrient insufficiency for essential vitamins and minerals, right?
Yeah.
So, and it's like it's just confirmatory that what we had already kind of learned, what we'd have intuited from putting that data together into a cohesive story, it's being told right here.
Yeah, you can see in the spider plot those four nodes, environmental, mutational, nutritional, and mitochondrial. That's
Yep.
really where the profile crimps inward, and that's what signals that insufficiency. So what page would you like me to go to next, Dr. Vickery?
So let's just go ahead and scroll down. Now, do you want to spend any time at all looking at these subsets under the various
It's
domains?
however you want me. Yeah, it's however you want to progress for the case
Okay.
study.
Well, yeah,
I'm
go
here.
ahead and go under aging, and then we'll look at those subsets primarily to point out one thing.
Yeah,
Well, two things. Look at her glutathione level.
her glutathione level is borderline low, right on the edge of the low reference
Yeah.
average.
And for somebody with that toxicant burden, I really want it way up there,
Yeah, absolutely.
And then look at her spermidine level.
Yeah, her spermidine level is really low, below
Yeah.
the reference average.
And then the niacinamide.
Yeah, so there we go. There's some mitochondrial impairment and impairment in 300
Yes.
niacinamide-dependent enzymes in the body. It's really a ubiquitous cofactor. So we see this as very low indeed.
When we first met, I told you before I was running Therium and I was running the comprehensive intra-extracellular nutrient reports, how one of the surprising findings to me was the level of niacin depletion across our population. And you were like, we're seeing the same thing on our test.
Yeah,
Yeah.
absolutely. It's a
Yeah.
chronic issue. Yeah,
So we obviously see that oxidative stress and antioxidant status, not great,
not
right?
great at all right here.
Right. So we've already said we think based on the other metrics we have an oxidative stress problem. We do have an oxidative stress problem. And then micronutrient linked metabolism. Right.
Yeah,
So yeah, we've got
vitamin E, niacin, and B6.
yes. And then we can carry on down and get into I think we can skip over the
You have
inflammatory.
some issues with nutrient sensing here, which
Yeah,
might,
there is
might
no,
like,
there's a deficit there, and
yeah,
the recommendation, what we'll get there was the berberine, which I thought was actually excellent for her,
sure.
for multiple reasons. It ties into her gut report as well. So under mitochondria, I always stop and dwell here for a bit.
Yeah, let's take a
So
look here.
yeah, so I had said, on that prodrome test, there's some evidence, but it's very mild of fatty acid oxidation. And what do we see? Just
Yeah, just a very mild. The stearic acid could be higher. Obviously, this is a healthy fat that we want to see.
yeah,
And then her palmitic acid levels could be lower, ideally in this domain. So
yeah.
definitely tied to some diet issues.
So yeah, so under the mitochondria again, and then we see NAD, with of course, I know that you're looking at more than just niacinamide for that domain, but we know we're going to have a problem with NAD,
Yeah.
availability. So there again, we have like a really nice congruency with what we were already suspecting with our other tests. Cardiovascular,
Yeah.
for her, let's see, apoptosis, mitochondrial function, obviously, um, ion traffic channeling and electrophysiology, obviously with, a history of SVT, which is really an electrophysiological problem, doesn't necessarily, index to these specific issues, but, there are issues in these areas when that's happening. But
Absolutely.
yeah. And so nitric oxide would be one thing that we'd be thinking about her for her.
Yeah,
Uh,
EMOS signaling was really low given our art
yes,
levels. Yeah.
exactly. So reproductive health, overall, normative for somebody approaching 50. Hormones we already went through, suggestive maybe perimenopause, but we couldn't really confirm it just based on the timing. I don't know if there's anything you want to comment on there. There's nothing I feel like I need to comment on.
No, no, relatively unremarkable. I would even say
Yeah.
that the slightly lowered metabolism of this integrated set of panels that we have for both male and female endocrine signaling is a little bit diminished, but again, it could be just be the cessation of menses in this individual.
Yes. So liver processing, we've a little urea cycle function impairment, some bile acid synthesis and transport. I mean, one thing I just kind of assume in a female that has lost some weight and has high toxicant burden, approaching 50, is probably bile quality is not great. So
Yeah.
it's a baseline assumption, which obviously impacts a whole lot more than simply the production of bile salts into the lumen of the gastrointestinal tract.
Yeah,
So
this carbohydrate metabolism is really interesting because her glucose was low, and then
yes,
glucose 6 phosphate levels are also low in our panel, and her insulin was low. So insulin obviously is what's going to signal to the cell, hey, translocate this GLUT2 receptor and bring glucose in. When glucose comes in, go ahead and phosphorylate it and commit that to intercellular metabolism. So when I see low glucose 6 phosphate, low insulin, I know that there's this aberration in insulin signaling. It's either insulin is not being sufficiently signaled, or glucose from the diet is low, or phosphorylation, either some kinase activity intracellularly has gone awry, leading to these lower glucose 6 phosphate levels. But it does very congruently, at least, with where these are in metabolism.
yeah, that's really helpful because I didn't actually know what to make of the carbohydrate metabolism like hit in this particular one. So obviously I went with the algorithms but that does, and now it kind of makes sense in light of what we saw in those serum markers. Her bone density was normal, actually really healthy on her actual DEXA. So at least at the time, it looked good, but we do see some risk, and especially if she's going to trend into menopause, bone mineralization and density and resorption, that stands out to me, right? That we want to make sure that we don't let her slip into a state of osteopenia, osteoporosis in the next 2 to 3 years.
Yeah, what we're really measuring here with these markers is the transition between osteoblastic activity and osteoclastic activity, or bone forming and bone resorption. So when we see this, we see that the cellular milieu favors increased osteoclastic activity, or increased activity of those cells that secrete these acidic substances that then resorb calcium and phosphate. But our calcium and phosphate regulators are right kind of in the middle, and oxidative stress is good. Bone mineralization here, as you can tell from these markers, Dr. Vickery, these are all mitochondrial metabolites.
Yes.
So this is something that really is important. And even citric acid is really at the center of the hydroxyapatite and helps stabilize that crystalline structure of the bone. So, yeah, very interesting. What are we going to go to next?
We're going to go on down to our neurocog, which really, she was a 58, so she was well into the normative range, and she didn't report brain fog or mood disturbances or anything else. Still working on her sleep. Looking at, her GABA was good. I don't see, but her serotonin, you can see down here, is low.
Yeah, absolutely.
Panise, you can correct me if my thinking's off, because this is we're all learning, right? We're all learning as we go, and access to this depth or this granular type of information hasn't always been available, and so I'm learning a lot through processing these reports and comparing them. But some of these areas, like I think about in an age-dependent fashion. So, yes, my daughter, she's 19, about to be 20. We ran Ethereum on her because I'm very interested in my kids staying ahead of things on their health. And her overall score was high normative. And some things were optimal. And, she's like, well, I need to go for optimal. But her cardiovascular score, for various reasons in the subsets, was actually one of her lower scores. Now, obviously, I could say, hey, I need to run this cardiovascular protocol that's recommended on you. But there were opportunities for improvements in mitochondria, in nutrition, other categories. And I'm thinking, if we fix those things, a healthy 19-year-old who's fit is a lot of the cardiovascular function is going to follow along. Does that make sense?
Yeah, absolutely.
Yeah.
Yeah. And
Yeah.
you and that's the correct way to interpret these metrics, Dr. Vickery, is to use it in the context of the age, developmental stage, life goals of that person. And so it's not always about what is the lowest or highest scoring domain, but how does that make sense, in the context of that person's overall
Yeah.
physiology?
So
Um, we see a
for
lot of similarities here in the integumentary health. I see ethanolamine is right in the middle, and their
Mhm.
ethanolamine plasmalogens were kind of right in the middle as well.
Yes, that's right.
Yeah,
Yeah. So in her case with neurocog, yeah, she'd like to have more focus and more alertness, but overall, she's doing really well subjectively in this domain. So, we're I didn't really I didn't get in the weeds on what's actually where are the areas of impairment. And there's only one that's really significantly impaired, and that was the second messengers and signaling molecules.
right.
Uh, Others look good. If you go on down to integumentary, she does have some active skin inflammatory issues, as we discussed. We can look at the skin barrier integrity and lipid composition and see that's problematic. Inflammation, oxidative stress markers, problematic, and then microbiome associated metabolites as well, which is great because we have a gut test on her. Not that I know we're talking about. Well, you tell me. Is
This
this
is skin, these
is
are
this
skin
this indicative of
metabolites.
the holobiome? Is this like are we looking at this through the holobiome perspective, oral biome, gut biome, and skin biome, or are we
So
looking at
it's mostly skin and gut.
that?
Some
Okay.
of these, like ribitol, have oral microbiome components. Of course, tryptamine and tyramine, these are going to be very much gut microbiome indicators. But a lot of these, like the transenamic acid, 2-hydroxysenamic acid, these are oral microbiome, or sorry, skin microbiome
Yeah.
indicators.
That's what I figured. But again, given that this is a serum assessment, then I figured it probably did cross match against some of the gut biome as well.
Sure.
And then we get into the environmental toxin, which we know we've got a problem. We saw it already, and we can see heavy metals, right? We
Boom,
can see some pesticides,
boom,
industrial chemicals,
boom.
endocrine disruptors,
Yeah,
yeah, air pollutants, plastics, consumer products,
products,
mycotoxins,
mycotoxins.
yes, radiation exposure. So clearly,
Basically everything except pharmaceuticals and illicit drugs.
that's right.
And
Yeah.
VOCs are pretty good too. The plastics are kind of right in the middle, but everything else is pinging perfectly.
Yes. So she has cleaned up she has a newer home. She's an architect, designed it. It's beautiful. But the air quality has already been attended to.
Great.
Yeah, you can see here. But she now has installed a whole house water filtration system that
Awesome.
I encouraged her to do. And they have completely cleaned up the food environment and the personal care product environment. They're like,
Wonderful.
yeah. And then we're, of course, running a protocol for it. And then finally, we have mutational load. And we see mutagenesis and DNA repair issues. And those are things you mentioned in the very beginning when we were just looking at her global assessment.
Yeah.
So, obviously, and that's a pretty low score, 33%.
Yeah.
And
That's worrying.
I personally, I mean, I think that not all, but many of the toxicants are, they are in fact carcinogens and increase stress on DNA. Do you agree with that?
Absolutely. And so let's hope this is a transient diminution of her
Yes.
mutational load score. And as prevention for when it comes to toxicants, prevention always beats treatment, right? And everything prevention really beats treatment, but it's really highlighted, I think, in environmental toxicant treatment because it's such a prolonged duration course of treatment that you have to really undergo. And if you install the air purifiers and the water purifiers, you're in a much better shape. So let's hope this is just a transient. And what I'm seeing is, mutagenesis, this is somewhat of a ingrained genetic measure, but the DNA repair is tied to this oxidative stress. And so if we can sort of really free up some of the impairments of these repair enzymes, then the mutagenesis score should be alleviated. They all kind of feed off of each other. And we're looking at the part of the mutational expression that we can change in our lives, not the part that is essentially hardwired. So should we move on to the protocol?
Yes. So, and again, you could look at our methylation efficiency index. Both of us agree this is our least favorite part of this report.
Yeah, yeah.
Yeah.
But if you're
But
really interested in DNA methylation, you
yeah.
want to take a look at your methylome, this is a great stopping point. And you can
Yes.
take a look at the methylation efficiency index. It's a marker of really born out of the breast cancer research and how well the flux is going through these methylation pathways. But That's already considered incorporated into the 12 health domains. We just kind of break it apart there. So we'll head to
Yes.
the protocol.
Yes, we will. So obviously, we've got a lot of targets for this individual. We're going to walk through the digital twinning recommendations. You can tell you tell me if you think the audience needs to understand digital twinning or if they already possibly do. It's up to you.
Yeah, digital twinning is essentially this for the audience members who are not aware of what we do. This is an bioinformatic assessment that we perform by rendering essentially a metabolic network of all of your metabolites. Here we see it done with methylation metabolites, but we render a network with all metabolites, and then each of our 1,300 interventions in our database undergoes 1,000 iterations on that digital twin, which is representation of that person's metabolic networks. And with every iteration of that intervention, whether it's targeted antioxidants or spermidine or astaxanthin. We are varying things like dosage, frequency, timing, with meals, without meals, and we're observing the response from that digital twin. We're then able to rank these interventions from most to least beneficial to even some that are predicted to be detrimental, and then we're able to curate a very personalized protocols, which will, as we'll see, list the dosages, the frequencies, the timings, effects to consider, and it's a very detailed analysis that really allows us to personalize. The personalization aspect is not just a word; it is a process that has to be undertaken with that in silico representation of a person's metabolism, and that's what Dr. Vickery is going to walk through with us now.
Yeah. And so what I've been doing is, obviously we were running protocols before we had digital twinning available, and we were
Yeah,
using a lot of these molecules because
absolutely.
they're all reflected in the literature around longevity, optimization, human health, etc. The beauty is I don't really have to guess. If I want to improve NAD, which precursor should I use? The report's going to tell me which one to use and at what dose is going to be optimal. So that's incredibly helpful to me. Whereas I used to have to kind of guess, measure. They were educated guesses, and we got a lot right.
Mhm.
But sometimes we were just a little bit off in what we were intuiting. So in addition, this is one a therapeutic intervention. I mean, the totality of this you could look at as a therapeutic intervention using these various molecules plus the lifestyle recommendations that come into the report. It's not all just take this. There's some, I mean, sometimes photobiomodulation is recommended, sometimes sauna, sometimes cold plunging. So a lot intermittent fasting. So a lot of the things that we talk about regularly in longevity and human health actually will show up in these reports personalized. And of course, we would recommend most people to consider you getting in sauna consistently and most people to follow time restricted feeding practices. But there are some individuals that are going to get a clear, unique benefit from doing so. And that would be representative. But we also have clinicians will have other protocols and tools that they like to use. And in some cases, the tools that they're using, they might even exceed the impact of some of the tools that are recommended. The difference
That's
is that they're just not worked into the algorithms yet because we don't have the studies on them yet. Am I saying that correctly?
that's perfectly stated. Yeah.
Yes. Yeah. So what I do love about Therium is it's based on, I can always tell my patients, this is firmly rooted in biomedical research. There's nothing showing up here where they like listen to a podcast and heard spermidine was awesome and just threw it on your report. Right? They're looking at studies for this. And yes, we all as clinicians who are treating consistently in our clinics, we may have tools that when we're looking at a particular area of cell dysfunction, we're like, I think this will be more powerful than that. And when I have that, then I'm probably going to substitute. And then, of course, we have peptides that we can layer into this and other things that we can do and IV. So there's a lot to be done. But what I'm going to do is walk through this digital twinning and show you how I would choose for this individual, the of the recommendations, how I'm going to choose them and put them together for her. Because also, Panise would tell you that the the predicted result that says, hey, in 6 months if you do this, then we don't have any major confounders that influence your health in the meantime, we're we're saying we should measure you here, right? Like, which I think
Yeah,
is,
absolutely. We put it on the digital twin and I'll go down
yeah,
a little bit.
which I think is
The
very
the retest timeline.
is an appropriately bold thing to do because you're saying
Ah,
if you've invested in our technology, you're going to trust it and you're going to change things about your life because of it. We're going to actually put our I don't want to say our reputation on the line, but we're going to say this is where you're going to get, and we expect to measure that.
Yeah,
That's a big encouragement to patients to actually see there's a target I'm going to move to, and then if we do execute in 6 months, we're going to actually measure that. And as we've discussed before, as we continue to integrate additional tools into these therapeutic plans, including potentially peptides, we might be able to achieve those targets faster or exceed those targets that
I
are.
believe so. Yeah. And we might have some metabolic trade-offs, right? We
Yep.
recently just published a Theriome paper in Trends in Endocrinology and Metabolism. It's a great journal with an impact factor above 11. And we talk about the concept of metabolic trade-offs. We can see on my screen here, her mitochondrial score is predicted to take some hit at retest.
Yes.
Does happen because metabolism unfortunately is a zero-sum game with all these metabolites being basically networked together. So as we pull or push one of these metabolite levels down or up, it is going to invariably affect the flux of related metabolites. Even in the order of two or three sort of orders of connections removed, we should see changes. So there are trade-offs, and it's still important that she observes the mitochondrial recommendations of some kind, or else the detriment to that domain could be even more. But I will let you take it from here, starting with the aging index or wherever you think we should start from.
That is important because some individuals, the most important thing to them may be aging, yet in the final digital twinning, the most impactful plan through digital twinning, the aging isn't the one that got brought up the most. But these other categories were brought up significantly, and you have to just encourage that person. Look, this is playing a longer game,
It's
right?
iterating, and yeah, exactly.
Yeah.
This is the long
Yeah.
game.
Yeah. And so that the goal would be ultimately, if possible, depending on age, environment, and other factors, to get every domain out to the optimal level. A 70-year-old, we may not get reproductive there no matter what we do, but we would ultimately, that would be our goal to get everything into the optimal range over time. So clearly redox, and we had already said this many times over, we know that there's going to be a problem. So we want to boost antioxidant defense systems. In this case, NAC is what's recommended. I completely agree. Great molecule for her. We're going to use it. Now, we also had borderline low glutathione in a heavily toxified person. So you'd say, well, why not glutathione? Well, you'll actually see in a different domain, glutathione is a recommendation. So it's you're going to see a lot of these recommendations in one domain actually cross-pollinate with other domains and have an impact. And of course, just for clarity, Penise, you can correct me again, but the first bullet point is considered the most impactful in that particular category. Is that still correct?
That is absolutely correct. And so
Yes.
in every category, whether it's aging, nutrition, inflammation, the first recommendations given are the most important ones to adhere to move that needle.
Yes. So in this case, we're going to definitely do NAC. And later you'll see that we're going to do glutathione. And we're definitely going to do spermidine. Her levels were low, right? And when there's an impact, so this clearly is a smart intervention. And I know that there's a upcoming Therium webinar where you're going to introduce the ability to use the personalized nutrients company, because I won't go into that today, but that's what we do. That's our methodology in our clinic. So we're actually able to work with a company out of Oregon, highest quality ingredients, highest purity standards. We're able to put these together into unified formulations. There would be a morning formulation, an evening formulation, a with meal formulation. So we're not trying to source this through 15, 17 different products and then open the capsules to try and titrate doses. We're actually able to make it very easy for the patient to introduce all these therapeutics.
Absolutely.
So
Personalized Nutrients is a great company that can do that. And again, we have no financial relationship with each other. The idea is just to put these tools in your hands that we know that adherence is important. Adherence is going to be made more accessible. Higher rates of adherence will be achieved if we can put these into these
yeah.
personalized formulations. And so this company is great for that.
Yeah. So when I discuss the things I'm going to use in this patient, we're actually, the vast majority, we're putting them together for her, and she doesn't have to go try to source them all. So in this
Right.
category, though, I'm doing all three because I love astaxanthin, not just for her lipid peroxidation, but the plasmalogen depletion I saw in her prodrome test and for other reasons. So technically we can adopt about 70% of these recommendations to reach the predicted score. Correct. Once again, sorry to keep asking correct, but
You got it. That's
yeah,
correct. You
yeah,
you know the test in some ways better than I do, Gus. Don't
yeah.
worry.
Yeah, so it's not like we have to choose every one. And this is where the clinician, your understanding of the patient, your skills, your experience, the ways that you know how to tell the story more completely. The Aristotle test tells you a lot of the story, but it doesn't tell you the whole story. And your skills as a experienced clinician who knows how to listen to patients and examine patients and look at data and put it together is critical to get the best results. And so that work is to decide as you go through here which of these, because there are some categories where you may choose to do nothing, but then there are others where you're doing all three, right? And you'll use your sense of that patient and their needs. So I'm definitely doing the astaxanthin in her as well.
Great.
Yes. Now, I did start her on a comprehensive nutritional formulation that I've created myself for our patients in our clinic that covers all the methylated B vitamins and minerals and fulvic and humic and carotenoids. So we went ahead and used our foundational stack because it actually has these, well, it really exceeds it on B12, but it has these doses of
Great.
these B vitamins, which we know that she needs. And then the glutathione. In this case, obviously, you'll continue until possibly Nyan has studies, but I use a transdermal form of glutathione that I know works very well and increases intracellular glutathione. Whatever the case,
We
we're going to.
have actually indexed it now. You'll see it called transdermal glutathione. Sometimes you'll see it referenced as cyclodextrin glutathione. We
Yeah,
have it referenced, and Nyan does have some studies, and so that's well, we just don't make the brand name recommendation unless
right.
it's actually that brand name in the study. So transdermal, you'll see it being probably recommended more often in the bone health domain for things like joint aches, used topically for local activity. I think that's what we will mostly recommend it for.
Yeah, but incidentally, just observation, everybody that I've gotten this test on, and at this point I've done a lot of these, as you know, that is actively using the transdermal. This doesn't prove anything. It's just an observation. But everybody who's actually using that, they all have, none of them have, they all have high levels of glutathione on their tests.
Yeah,
Uh,
it seems that way. If you're using
yeah,
Glutathione, your
yeah.
glutathione is through the roof on our tests. For the most part, I would say 95% of the people we've tested who are like that. I'll give you a funny anecdote over the weekend actually of one person who had this sort of result. But yeah, so you're giving them the glutaril and you're benchmarking it, you're paralleling it against our dosage.
Mhm. Yes, that's exactly right.
Right.
So we're going to introduce the glutathione and absolutely with the nutrient sensing issue and what we're seeing with the nutritional score, with the glucose, with the insulin, we're going to add the berberine. So here we've done 100, we've done 100% of the recommendations thus far. Inflammatory, she didn't really have a bad score, but I really do like curcumin for her for many reasons, gut and brain and mitochondria and NRF2, I like it for all those reasons. So we are going to do the curcumin. And then we're going to, because she did, even though she didn't have a bad total score, that viral inflammation category was not good. We went ahead and we're doing the lysine as well. The omega-3s, of course, we're already, we already saw the
Saw that in
deficiency.
the prodrome.
Yeah, yeah. So we're gonna already have her on a very healthy dose of omega-3s. Now, what this does is tell me she actually needs more at this point than the average bear, so to speak. Most people, if they eat, depending on their diet, they might 1,000 milligrams a day would be good. But in her case, we're really going with a 3.5 gram dose. So a lot of EPA and DHA. So we're able to, in the custom formulation, we're able to take whatever else we're already giving her, subtract that out, and then complete that. But yeah, we're definitely doing the omega-3s. And I'll generally do everything on mitochondria, everything.
Everything. All right. So they're
Yeah.
getting the NR.
Yeah. So we're going to get the nicotinamide riboside, precursor for NAD, the alpha ketoglutarate, so that we can kickstart the TCA cycle. We saw issues with her on that particular area, and we measured a low CoQ10 level. So
Did.
absolutely, go
Yeah.
ahead and put her
200
on
milligrams of that.
CoQ10. On the cardiovascular, her carotid IMT is phenomenal. No evidence of endothelial dysfunction, no evidence of plaques. It doesn't mean that she couldn't develop them, but ultimately, my focus for her in that particular area was the nitric oxide. And also her salivary nitrite test was depleted. So she's missing on that pathway, and obviously NOS for a near 50-year-old. Maybe it's working well, maybe it's not working so well. We don't know because we can't measure. So I started her on a nitrate-based support product for nitric oxide to work on the salivary enteric pathway for nitric oxide production, and she's going to do the citrulline as well because partly I gave her a pass on that one. I said, well, let me optimize nitric oxide through this other way.
Salivary, yeah, and
Yeah,
confirm that before you pump her with the citrulline. Yeah.
that's right. But what she wanted to do was add citrulline before workout. So I said, sure, we can do both.
Okay. All
Yeah,
right.
I know. And then the magnesium threonate, again, I might have said, maybe we can take a pass on
Oh,
channel trafficking and fix other things and then look at this again later. But because of the impact on her at night for sleep and calming the nervous system, I thought it was a great idea. Yeah, I'm just being like honest about my
yeah,
thinking.
yeah. It seems like a lot of them, but even at very critical points, you are using your deep knowledge as a physician and all the cases you've seen to modulate the therapy in some way, whether that's a transdermal glutathione patch or fixing this nitric oxide issue before you really push the citrulline. So,
Yes.
um, yeah, this is really great for my own edification as well.
Yeah, so I liked this for, again, this is one, it's the bottom of the list. I don't want to overwhelm her. I take the pass, but I think that for possible sleep benefits, that it's worth, that it's worth going ahead and adding in. And she's a go-getter. She's like, you give it to me, I'm going to do it. She's after it. So she's an easy one to work with. I've got other patients where I really do have to keep it to the 70% and
Yeah,
pick and choose more carefully because their tolerance for capsule load or cost is just going to be impacted.
yeah,
So on this part, she's I know we know what the test it's measuring. She's not reporting menstrual challenges at
yeah.
all. That doesn't mean there's not issues with metabolism of reproductive hormones and balance. She's
That's exactly what we're going after is hormonal balance.
Yeah.
Yeah.
And so she's not reporting any symptoms related to this. And she's probably trending into menopause. And we're going to do some proactive serial measurements of FSH, estradiol, progesterone at different times of the cycle. Her ovaries are going to eventually, reduce their function. So in this particular case, I told her that if we were getting to a point of overwhelm, that we could choose to take a pass and say, let's focus on everything else
Sure.
and
Makes
come back,
sense.
yeah, come back to this later. So that's just for the clinicians listening. If you're a patient who's already like, oh my gosh, this is too much. I mean, this is one in her particular situation. We don't have any subjective complaints. We don't have any serum markers that say there's a big problem. Obviously, I didn't do a Dutch test. And she's going to she's going to transition to menopause in the next 1 or 2 years, probably anyway. We're like, we can work back around to this later. But guess what she said? Wow, I want to do it. Yeah, so we went ahead and introduced it, but I
Wow.
wouldn't have pushed that for her. So phase two detox, clearly, and with detox, this is so important. So often we jump straight to, like you mentioned earlier, the treatments, the binders, everything, the bioactivators, all of that, and don't think about the body's capacity to run phase two detox. And
Yeah.
it's so critical that we actually really boost that first, more
Yeah.
so that system can do its job, and then really run with how are we going to proactively clear the
And I
body.
see we're giving even though her glycine levels were good, I
Hmm.
see we are predicting some glycine depletion with the NAC we recommended earlier. So
Yes.
NAC is being recommended with glycine, which are both required to create glutathione. And so we're
Yep.
we're predicting this expenditure of glycine that'll come with this addition of NAC, and we're supplementing it with a pretty moderately to high dose of glycine, 3 grams.
Well, that was what I think the study dose was 3 grams that got Glynac so popular. So it's
Yeah.
yeah. But also, so what's one other, what would be one other reason I actually like glycine for her sleep, So
Yeah.
we were like, let's do it. And she's obviously, let's do it. And then I'm a big fan of alpha lipoic acid. It doesn't show up on every report. It does show up on most of them. And I think that's because of the impact that it can have for individuals. And there's a reason why you choose to add it. But so in her, I would have honestly at this point been willing to go. I really thought the TUDCA was critical for bile flow and gut biome. And
Yeah.
so I would have actually chosen 1 and 3. And if she was at a point of like, I can't do anymore, this is it, and probably gone with these two, based on what I want to accomplish with her, especially in the detox realm. But because she's a go-getter, we're doing the alpha lipoic acid as well, which I'm happy about because that'll also support further intramitochondrial, oxidative stress as well. And then with the bone health, we've already got her on the 180 micrograms of MK7. Already got her going with some collagen powder with protein, with her protein, both for gut and for systemic connective tissue. And then the strontium was easy just to go ahead and put into her formulation
Okay.
as mineral. And then we have neurocognition, which this is an area again where we could have said we'll take a pass for now.
Yeah.
But she loved like the lion's mane. She loved the idea when I explained to her what lion's mane does. She was like, I want it, give it to me. So,
Sure.
and then the acetylcholine and then the theanine, which again, for me, I'm trying to get her nervous system into a calmer state and boosting inhibitory neurotransmitters and serotonin, et cetera. So I was like, hey, theanine, it'd be great for you. So we're actually doing them all. But again, if she had gotten to a point of I'm fatigued, this is more than I'm going to be able to do, I could have taken a pass on this category for now.
Yeah, I mean, you can see that we're prioritizing the lowest scoring domains. Here we have a domain that's scoring 1, here it's 3, and here it's 4. So we have, very poor, normative, and slightly optimized domains that are being targeted with, the greatest impact being this first one, the citicoline recommendation. So this is great to see how you use it. What
Mhm.
about tegumentary health? Do we give anything for her?
Yeah, well, the ceramides for sure. Explained that, and that's easy enough to do. We've already got the collagen peptides going. We did skip the gamma linoleic acid.
Okay. Yeah. I mean, if we don't see a lot of inflammation,
Yeah.
that's great.
So we went with the collagen and the ceramides.
So here's the big one. What do we do for the environmental toxin?
Well, your protocols are great, but I've got a more robust detox protocol set.
That's great.
Yeah,
What did we use?
yeah. So I use Cellcore, and
Okay.
I don't know if you're familiar with them.
We're going to one of their conferences in the near future,
Yeah,
actually.
Cellcore is phenomenal. Their products work. I knew they worked before I started using them because they actually showed the data. And
Sure.
it's a unique set of the binders are different chains of carbon. There's combinations of fulvic and humic with these different binders. They have a mycotoxin binder or a biotoxin binder. They have a specific heavy metal envirotoxin binder. They have drainage activators, bile support, TUDCA. And we've been running Cellcore protocols on patients with toxicant reports for 4 years now. It works,
Yeah.
right? If you clean up the environment, you support phase 2 detox,
Right.
and you add their protocol in, you will measure. When you remeasure, you will see a substantial drop in toxicant burden in that individual.
Absolutely. That's I mean, those are the three levers we can pull, right?
Yeah.
Like cleaning, like ceasing the introduction of these environmental toxins from the environment, improving the liver's ability to handle these, and then sort of optimizing this with these binders and bile acid synthesis precursors. That's exactly it. So which of these did you use and which ones did you kind of
Well, so we are using for cell core, we're using a dedicated cell core protocol. So I'm not actually using your recommendations.
okay. That's fine. I'm
Yeah.
glad that your talks panel and our talks panel agreed. And
Yes.
if you have a better way of doing it, that mean that's exactly what a physician should be doing.
Yeah,
Uh,
whether it's better or not, I don't know. I've just proven it works.
sure.
And yeah, and also her and now granted it was a long interval, but we saw how there was a pretty substantial reduction in many of the toxicants that were on her original panel. And again, it was a long time span, so I'm not going to give the credit to this, but what we had done at that time was run a cell core protocol.
Yeah.
For several months, and then we had to repeat it a couple of months after that. I do believe it probably had some impact on those levels that were kind of hanging around in our system. But
Absolutely.
we did do the glutathione. So we did one of the
You did
three.
do. You did the liposomal glutathione. Great. That's
Yes.
excellent. While
And
we
then,
wait for that
yeah,
NAD to be metabolized, let's give her a big boost right now.
yeah, and so for mutational load, we went ahead and jumped in. We have the astaxanthin already on board, and we have the resveratrol. Well, I added the resveratrol. I thought that would be great for her. She was ready to do that, and we also know that there was a pretty significant issue here. And I was gonna again give her a pass on the sulforaphane. I was just because we were doing almost everything else, but given the mutagenesis concern.
She
uh,
said throw it in there.
yeah, I was like, why don't we just go ahead and get that done? And she did. So, obviously that's a lot, right? I mean, this person is going to be taking a large number of different molecules at different doses, all, and some at different times, but we were able to put it all together for her to make it as easy as possible. She's not opening up 18 different bottles, just a
No,
few.
you're compounding it into one
Yeah.
or two things that she's using, and
Yeah.
all of the risks associated with polypharmacy, whether they are contraindications or whether there are risks of toxicity, that has been checked by our digital twinning. And so the protocol is meant to be working synergistically,
Yeah.
such that absorption and timing is considered, and contraindications and toxicity are mitigated and altogether avoided.
Yeah. And so obviously with her cell core protocol, we're very specific on the timing of when she's going to use that separate from some of these other molecules. Because what we don't want is for the powerful binders to end up potentially impacting some of the other things that we're putting into her body. So she has a very specific sequence for how she introduces that. And again, we didn't have to adopt every one of those. You could, if you were like, I want to affect all 12 domains, you could go with the first two of the three, the most impactful. But as you can see, I'm really thinking through her whole case. I'm thinking through her health history, her goals, and where I really want to push in deeply, where I could, say, hey, we can come back around to that later. I do know that as we improve many of these domains, others will often come along for the ride. And so
Absolutely.
yeah, and so we can, do it that way. I mean, it wasn't obvious. I used the nutritional stack. We also, I have our own bioregulatory peptide stacks for epigenetic age shifting. There are other tools we're using outside of what we've just put together. But I want to say that if this was all I had, I can reflect back over my 20-year career in medicine and think about all the different testing modalities and intervention plans that I've had. If this was the only test I had and the only interventional plan I had, and we could clearly measure sequences of improvement to optimization, then that's ultimately the goal, period, right? And so it's just such a really amazing tool.
I do want to say just a few things that I picked up. First of all, and I hope you agree with me here, is that this test does not replace you, the physician, whatsoever.
No.
Not at all. And I think we are decades away, if ever, to replacing that, to be able to train AI on that tacit knowledge that physicians pick up over decades of practice. It is meant to be, I think, a very comprehensive data capture endeavor with a very sophisticated bioinformatic apparatus attached on the back end. And this is meant to serve as a co-pilot, a touchstone. It is meant to give you a deeper look and a very sensible, cogent digestion of what's going on biochemically. And like we've assessed through comparisons with the other labs you're using, it does fit nicely into this overall clinical mosaic that you build for your patients. It confirms and at times I think extends the logic presented in other tests. So that was really great to see. What can you say as far as, AI's role and how a physician should be using it?
And this is just my opinion, which might vary from other people's opinion. So I would just receive it that way. First and foremost, what I can say about AI, I have my areas of concern, right? Of what can be done with AI technology that could be very deceptive to our population. And I'm not talking about politically, I'm just talking about all kinds of things that people can do with it. I don't personally want AI to write my poetry, or it might be very good at it. I'm sure it is, or compose my music or draw my art. I really want that to be other human beings. That's just
Absolutely.
kind of how it's made. When it comes to the biomedical applications, there is no way that I could spend my entire career looking at these 126 metabolites on reports, index them against other tests, evaluating a patient, making my best guesses, remeasuring. And maybe by the 20th year, I would have some level of competency in terms of really being accurate at how I interpret it. I don't think this is possible without AI, and certainly the digital twinning, right? That which creates such a precise, nuanced, personalized plan for that individual based on biomedical research. And so I I'm really excited that we have the capacity, and I believe strongly that AI will be the future because, as I mentioned earlier, this the presence of a disease in our population, and I don't mean just diagnosed diseases, I mean poor health,
Yeah.
uh, dysfunctional systems is
Yes.
a big, big problem starting now in utero during fetal development.
Unfortunately.
And if we don't find a way to begin to better understand what has affected this health trajectory, how do we change it? Our species is not going to do well over our next generations.
Yeah.
We have to be able to better understand this, collect the data, present the data, make the compelling case that food quality really does matter a lot, right?
And
That
environmental toxins are affecting children in utero.
Yes. Yeah, exactly. So I feel really fortunate that during my career in medicine, that these tools have evolved, right? That I have them now. And as you can tell, and I'm sure the people who view this will be able to tell my excitement. It's a genuine excitement. Uh, and we just spent an hour and a half going through all of this. I want to be clear with experience. My review that I would have done in this consult before I met with the patient, where I looked at each of the databases and then I looked at the metabolomics report and cross-matched it. That takes 15 minutes. In
Yeah.
15 minutes, I know exactly what I'm seeing in the patterns, and then my discussion is going to kind of, help bring some nuance to it and where we're going to go and what we're going to do. So we talked through it at length, but once you get your mind around what you're looking at, it's a very quick process
Yeah.
to be able to know what you want to do with the tool.
Dr. Vickery, thank you so much for joining us here today. I'll leave with just one comment, both on our test and your practice. When we talk about medicine 3.0, when we talk about, we had, germ theory, we had antibiotics, and now we're here. One thing that, is very important, of course, when we talk about scientific wellness and the principles that were really propagated by Professor Lee Hood and Nathan Price and people who are working in this space, they've really framed everything as this lens of P4 medicine. That medicine should be predictive, personalized, preventive, and participatory. And this is a hallmark of the paradigm shift we're seeing to medicine 3.0. And what I can say is that the way you use our test in your practice, I think really does highlight this. So you're looking at predictive markers. You are implementing preventive strategies. These are personalized strategies that are targeted and refined through the process, the iterative process of digital twinning. And of course, you have an extended discussion about the data and contextualize that within the parameters, the socio-demographic parameters of their lifestyle. And so in that way, it's participatory. You have a discussion with your patients, and Theriome is one piece of that discussion. But absolutely commend you. It's been such a privilege to be supplying testing for you and to work through these case studies with you. I won't take up any more of your time today.
But
Thank you so much for that very deep, detailed dive into our testing and how it fits into your practice. And
thank you. This is a real privilege for me. And the last thing, because you got to go, that participatory piece,
yeah,
actually, I want to be clear. This doesn't diminish the relational aspect of medication, of medicine, practicing medicine. It enhances it. It
absolutely.
absolutely, the patients light up with this type of detail and this understanding. So it's not like suddenly I'm becoming less important and the relationship, all we need to do is follow the algorithms. It's
Yeah.
becoming more important. So this amplifies that relationship and trust and confidence the patient has.
Absolutely. It's one thing to do to adhere to an intervention. It's another thing to understand why.
Yeah.
So thank you so much, Gus. It's been a pleasure and looking forward to chatting with you soon.
Thank you, Denise. Have a great day.
Bye.